going in, and that's breaking down into capillary loops. And then this efferent arteriole that coming the blood, and that's part of the distal convoluted tubule. We call it that of the afferent arteriole called macula densa. Just keep it in mind. This here in the afferent arteriole, the wall, we have the myoepithelial cells making the juxtaglomerular apparatus. As you'll see in the capillaries, usually they are breaking down into capillaries. They are held together by the mesangium, 1 to 3 capillaries, held by the mesangium. Now, at higher level sketch presentation, we have this is the capillary loop. We have the outside the endothelial cell sending its foot processes over the surface, and then we have the endothelial lining, which is the endocytes, and sending its cytoplasm into the lumen. And look about, it's not a complete layer, it is fenestrated. And that's important for later talk. And this is the mesangium that usually holds several capillary loops together. Now, this is the normal looking glomerulus. This is the hilar area, and we look here and we see different capillaries, 1, 2, 3. There are 1 or 2 mesangial cells in between. This is the basement membrane, looks fine and not thick. So when we look about the glomerulus, we have to look about the capillary basement membrane. We look about the lumen open or not, and the number of the mesangial cells present there. This is a special stain. Look how nice, neat the capillary basement membrane, smooth lining, number of cells that present here. Now with electron microscopy, as you'll see, this is scanning microscopy. We have this the epithelial cells and its fruit processes over the tubule. And that's a cross section of the electron microscopy. This is the capillary lumen where the blood is percolating. This is the endocytes, which is cytoplasm, fenestrated. This is the basement membrane, as you'll see, components, interna, lamina externa, laminar interna, externa, and that's the basement membrane proper. And that's what we have, the epithelial cell sending its foot processes. Just one word of caution really here. Look about this. The width of the basement membrane here should equal this basically. Most of the time, the base of the foot processes, most of the time equal to the thickness of the basement membrane. For any substance to cross from this lumen to the urinary system, urinary space, it has to go through the endothelial lining, which is the endothelium with its fenestrated base, the membrane, and then the epithelial layer. Look at what's happening here. This is the lining of the cytoplasm with its fenestration. This is the basement membrane, and then with this, you see the foot processes of the epithelial cells. They are not connected. There are between them, there are openings here. We call it the slit diaphragm. These are important structures that we have here. And if you see, the foot processes are really standing out individually. They are not smudged. That's because they have a negatively charged substance. We call it sialic acid on the surface, keep it at really spread. So for a substance to go from the capillary lumen into the Bowman space, it depends on two things: the size of the substance, and the larger the substance, the more difficult to pass. The smaller the substance, it's easy to pass through the fenestration, through the basement membrane, through the slit diaphragm, so to reach the, and that would be reflected into later on talking. Look about this. That indicates the substance that can go through. The molecular weight of a substance, here is water, here is urea, glucose, and we go all the way to albumin. And as you'll see, when you go further with the larger one, it's more difficult to pass through, and depends on the configuration. As it seems here, look about the clearance of a substance depends upon its molecular weight and filtration. With albumin being 96,000 Dalton, it's the most difficult one really to pass through. And then you have the myoglobin, for example, 17,000, it's easy to pass, while hemoglobin is 68. Again, depends upon the charge, as we'll see later on. So it's not only the size of the molecule, but also the charge of the molecule. Remember that the food processes are negatively charged. So any negatively charged substance to go through, it's really difficult. It will be repulsed back. While positively charged substance, it's easily to come. And that's why albumin, we know that albumin is a negatively charged substance. So it's very difficult really to go through. And that's why the sieving effect of it is quite significant. It will make it very little amount of albumin in the urine. Look about here, that's the dextran, which is a neutral dextran, no charges. When you have positively, negatively charged, and that's positively charged. So the clearance at any given time of radius depends upon also the charge of a substance. The more positive, it will be cleared better. The more negative, it will be less. Now, what about the immunological background of a substance that we are dealing with? That's the general module of immune complex disease. We have an antigen that present in our body, goes into our body, whether endogenous or exogenous. It will form antibodies. Now, these antibodies, with the antigen, they form immune complexes. The fate of these immune complexes really depends upon its molecular weight. The large and small molecular weight immune complexes will be cleared by the endothelial, by the reticuloendothelial cell, while the small size, it's really, that's the trouble with it, because it has to go through microcirculation. So it's being trapped into the microcirculation, basically the kidney and choroid plexus is in the eye. Look what happens when these immune complexes are trapped in the kidney. They will really stimulate the complement activation of the complement system with the chemotactic substances calling for polymorphonuclear cells, start forming these immune complexes and damage to the basal membrane. This is for the immune complex modality. And that's how it looks really with immune fluorescence. That's a granular pattern of immune complex deposits in the basement membrane of the capillary loops. And that's another one, in a patient with lupus, what we call lumpy, pumpy deposits that you're going to see. Now, the story is different when we have specific antibodies, anti-GBM antibodies. The antibodies present in circulation, they have specific site of binding, not randomly, specific site of binding to the basement membrane. So look what will happen here. They will attach to the basement membrane, they cause the damage to the basement membrane, and that will be reflected into a linear, nice linear staining of the capillary basement membrane. Now, another definition you have to remember, because we're going to go through nephropathology, you hear really about focal and diffuse, segmental and global. Remember, please, focal indicates the numbers, diffuse the numbers. So if you call focal glomerulonephritis, if you look about the number here, you have 6 glomeruli, 2 of them are affected and 4 are not. So this is a focal process. Now, if you have all of them, almost more than 50% affected, so you call it diffuse. So focal or diffuse depends upon the number of the glomeruli that being affected. Global or segmental, on each individual glomerulus, that depends. Part of the glomerulus, that's segmental, or the whole globe. So you may have diffuse global, you may have diffuse segmental, you have focal, global, you have focal, segmental. So focal and diffuse concerning number, global segmental for individual glomerulus. Please keep this in mind. Now, what are the patterns of renal injury that we see glomerular injury? You may have the epithelial pattern, you have the endocapillary pattern, you may have the mesangial pattern. Each one can be affected. Now, there is no absolute separation of this. There is an overlap. You may have endocapillary with epithelial, endocapillary with mesangium, and you have all three together, you may present with this. Now, let's look about what diseases will give you this. Epithelial cell injury, it looks like podocytopathy, we call it, minimal change disease, focal segmental, and membranous. Mesangial injury, basically mesangial proliferative GM, and you may have mesangiocapillary. Endocapillary injury, diffuse proliferative GM like exudative crescentic GM, thrombotic microangiopathy. And don't forget later abnormalities, basement membrane abnormalities. If you look about what will give you epithelial, what will give you endothelial, what will give you this, look about lupus, lupus, lupus. So lupus, a disease of all tablet. Let's see each one. Now the epithelial pattern of injury, as I mentioned, membranous, membranoproliferative, lupus type 5, minimal, and focal. How they present? Massive proteinuria. So when you have a patient presenting with nephrotic syndrome, you have to think about these pictures. Membranous, focal, segmental, and lupus always there. And that's basically what's happening. This is the sketch of glomerular capillaries. That the mesangium, there is no change in the mesangial number of cells. The endothelial lining, there is no exudation, there is no proliferation, but most of the process, as you'll see, it's epimembranous, epimembranous. So that's podocytopathy. Massive proteinuria is the hallmark, which means nephrotic syndrome. So if you have this presentation, you have to think about this list of diseases that you have. This is the light microscopy, nice, beautiful glomerulus. That's the hilum, capillary loops, mesangial cells are not increased. So this basically a normal looking glomerulus. If you have electron microscopy on this, look what you see. This membrane looks fine. Endocytes, endoplasm looks, the food processes are fused and supposed to be like this. That's the normal, supposed to be like this. If you have a glomerulus like this, one part is affected, the other is not. So that's segmental. And if you see part here like this, the rest of the glomerulus looks good. If you look here, this glomerulus looks perfect, but this part is affected, so that's focal segmental. How it looks on electron microscopy, that's a normal capillary loop. Look about the sclerosed, glomeruli, damaged capillary with all these sclerosing substances. That's a normal looking one. If you see here, the basement membrane looks thick. That's a pattern of injury. This is a pattern of injury. As you'll see, thick basement membrane in comparison to what you are seeing here. If you have silver stain, lucky enough, look about these spikes, nice capillary mesangium, but these are the spikes with the silver stain. Higher magnification, beautifully illustrated. These are the spikes separating between the large immune complexes as it's appear in this corner. This is the immune deposit, and these are part of the basement membrane, immune complexes, and that's really what will give you this as the spikes on silver stain. Lucky enough, if you have IgG immune staining, that's a granular pattern. Granular capillary pattern, not mesangial. And that's epimembranous. Look about how thick the basement membrane with all these deposits present there. So that's classically a disease of the podocytes that present there. Let's move on to the epithelial pattern of injury, where you have the endothelium, it's being active. There is some call for exudation. Why really it causes inflammation? Because this is in proximity of the bloodstream. Here the bloodstream and the components are away from this, so there is no chance for activation of the complement system. But here you have your immune complexes in contact with the blood, so basically it will enhance the formation of inflammation cytokines and exudation will cause. How they present? Hematuria. If we're talking about this now, forget about this. We're talking about this. If we go to this pattern, which is the mesangial pattern of injury, they present with hematuria, IgA, membranoproliferative, and lupus. Lupus will be there, IgA, IgM, diabetic sometimes, and deposit disease, it may present with this. Sketch, normal looking capillary loop, normal looking podocytes, but the mesangial cells are increased in number, as you'll see here. When you have immune fluorescence study, these are large deposits, mostly IgA, within the mesangium. This is not really capillary. That's a nice slide. Look about compare this normal glomerulus with this mesangial, increased mesangial matrix. And not only that, the number of the cells. We talk about 2 to 3 cells per hypobar field. Look about this, markedly increased number of cells. So this is a mesangial pattern of injury, mostly IgA. If you look about immune fluorescence, that's what you have. Deposits, capillary base membrane looks perfect. These are the immune complexes that present in the mesangium. Same thing, nothing in the basement membrane, most of it in the mesangium. What about the endothelium that I alluded to? Inflammation, proliferation, hematuria, decreased GFR. That's the classic what you see GM. Sketch presentation, epithelial part looks perfect, basement membrane looks perfect, but look about this. It's a bloodless glomerulus. Marked inflammation and mesangial cells, endothelial cell proliferation, pressing the capillary lumen to the point that there is very little blood to percolate through. And not only that, you start seeing humps, subepithelial humps that you see. This is classically, you can see it with post-infectious. How they present: hematuria, edema, azotemia, hypertension, active urine sediment, RBC, CAS most of the time, and it's an inflammatory glomerular disease. Typical example is this. If you are lucky enough, that's what you'll see. This is red cell cast. Again, we do see from the epithelial endothelial injury, rapid decline in GFR, we call anti-GBM antibody, Bausi immune, lupus nephritis, again, post-infectious, membranous cryos, a list of diseases, it's really growing. Look about this biopsy here. 1, 2, 3, 4, 5 glomeruli, all affected, more or less to the same degree. So this is a diffuse process. It's inflammatory, marked increase in the cells. In fact, you may see some crescents occasionally here. That's what we are talking about. Marked increase in cells, matrix, even necrosis. So that's an angry looking glomerulus. Immune fluorescence, that's classic of lupus, what you call it, lumpy-bumpy disease. Large immune complexes that you are seeing. If you are lucky enough to have electron microscopy, see how nice the basement membrane. It's not thick. Foot processes, decent. But look about all these massive subendothelial deposits. This is what you see with lupus type 4. Now, post-infectious, you see a large number of polymorph nuclear cells. And that's the term, they call it exudative GM. Like in this slide, from a patient with post-streptococcal infection, it's all markedly increased number of the cells. You basically don't see capillary opens, and all these, most of it are polymorph nuclear cells. Immune fluorescence, that you see granular deposit, IgG mostly, and if you are lucky enough with electron microscopy, that's what you see, subepithelial humps. Another pattern of injury, you see here, classical, what we call it, lobular pattern of injury. If you see this, that's basically membranoproliferative. You have the mesangium with the good inflammation, and you have the membranes are thickened. So it's membranoproliferative or mesangiocapillary. And that's here more illustrated with this, how nice this lobulation. So the pattern here is a lobular GN, and as you'll see, basically there is no open capillaries, and very few with thickened membrane. In fact, you are lucky if you can see duplication of the basement membrane. as you'll see in this slide. Very nice duplication of the basement membrane. Here, duplication of the basement membrane. So that's the hallmark of membranoproliferative. On electron microscopy, that's part of the basement membrane, that's part of the basement membrane, and that's a new material inflammation in between. That's what you call this tram track appearance. If you are having this patient with lipofuscinal dystrophy, then your diagnosis is membranoproliferative. As you'll see, this is typical facial lipodystrophy. More importantly, you may see this kind of pattern, which is a lobular pattern with nice, thick ribbon-like eosinophilic structure with inflammation, increased number of cells. You have membrane that's basically will trigger something we call dense deposit disease, as you'll see in the electron microscopy. Very dark, smooth outline, ribbon-like structure. This is dense deposit disease or type 2. Now you have to classify it differently, C3 nephropathy, and with or without immune complexes. And then we'll come to the last pattern of injury. When you have the capillary looks good, the basement membrane looks good, mesangium looks fine, but there is this cap, large amount of new cell formation, that's Bowman's capsule, developing from within Bowman's capsule, pressing the capillary, we call it crescentic GM. That's the crescent. At least you should have 3 layers of cells to call it crescentic, as illustrated here. And this is the glomerulus squished in the middle. And all this is what we call crescent formation. Look about this patient here, biopsy from a patient with RPGN. That's the glomerulus being tuft and all this circumferential crescent formation. If you see crescent formation, then you have to look for immune fluorescence. We know that you classify them into type 1, type 2, type 3, type 1 linear, which is anti-GBM antibody, type 2, which is granular capillary, that's immune complex, and if you don't see anything, you call it Pauci immune. That's very nice linear staining, like what you see it here. That's classic of anti-GBM antibody disease. If you don't see anything, but you have more necrosis, as in this area, so that's if you have to think about vasculitis. The rest of the glomerulus looks fine. The glomerulus looks fine. Just VH. And this is here an inflammation. Okay, it's a necrosis, what you have. Then in the old days, what we used to do, that's immune fluorescence, C-ANCA, and that's P-ANCA. Nowadays, we call it PR3 and MPO. Currently in our hospital, we just do the serological MPO or PR3, and we don't really anymore do this kind of immune fluorescence. Thrombotic microangiopathy, that's again a pattern of endothelial injury. If you'll see here, that's a blood vessel with a nice afferent area, afferent coming here. It's a clot formation within the glomerulus. Nodular pattern of injury. Now we are talking about nodular pattern of injury. If you see nodule like this, you have to think about diabetes. And that's classically diabetic Chemistyle-Wilson disease. How the electron microscopy will be, nice, smooth, thickened membrane. That's the RBCs. There is very little inflammation inside. Nodular, you can see it also in amyloidosis, like in this. It's basically no cells whatsoever, and that's congruent stain present in the glomerulus, in the capillaries. If you have immune fluorescence, that's what you'll see. Apple green perfringens. Apple green perfringens in the blood vessels, and you see it in the capillaries. That's control for another thing. That's control, and always we do control with it. Look about how nice the apple green staining. Nodular, you can see it also with Kappa light chain, monoclonal immune deposit disease. The characteristic of that, it's deeper in color than what you see in amyloid and diabetes. Not only that, you can see in the capillary Bowman's capsule, also it will stain. Not only that, look about the renal tubules. They will stain dark with this because of the immune deposit, monoclonal deposit disease. You revert to, if you find this, you have to have electron microscopy. What you'll see here is fibrillary structure. This could be amyloid, could be fibrillary or immunotactoid. So you have to have measurements. I put for you here the amyloid, which is roughly you can 10. This is 20. They are randomly. And then you have this here, which is really nice organized structure, microtubules, and its length usually around 30. So in order to, for the fibrillary structures, you have make it 10, 20, 30, 10 amyloid, 20 will be fibrillary, 30 will be immunotactoid. Last of the pattern usually is the basement membrane abnormalities, which we are talking about thin basement membrane and Alport disease. As you'll see, this is the normal thickness of the basement membrane, around 343 micron, the nanomillimeter. And usually the foot processes basement, more or less, will be close to this. Now, when you have it less than that, 214 plus minus, that we'll call it thin basement membrane disease, like you see in this pattern. See how thin. Compare this foot processes base to this, it's double. So that means you are dealing with thin basement membrane disease. Finally, about the complement system, because that's important for us later on. You have to remember the complement system. There are 3 pathways to activate that complement system. More importantly for you is the classic pathway. When you have the early components of the complement system, C1q, C1, C2, C4, and then the C3. The alternate pathway, C3, and then they will come ultimately through this 5 until you have the membrane attack complex that will cause the damage, C5b9. But you have to remember, in the classic pathway, the early components of the complement system will be depleted. In the alternate pathway, the early components will be saved. There is no affection of quite important, as I'll show you in the next slide. Then you have the lectin pathway, which is more or less, which is mannose binding lectin. It can really proceed more or less like the early complement component of the activation of the system. I put this slide for you here. Concerning complements, when you see it, you have to look for C3, C4. C3 low, C4 low, that's the classic pathway. 2 disease entities, lupus and cryoglobulins. If you see C4 normal, C3 low, then you have to think about the alternate pathway, and that will be membrane-operative GN or post-infectious GN, including C3 nephropathy. So that's the value of the complements. The rest of the glomerular diseases, IgA, henoxal line, membranous, Goodpasture, focal segmental, idiopathic, ANCA-related, all will be really normal complements. So really the normal the complement system, when you order that, it will help you a lot to reach your differential diagnosis. Final slide about this introduction, which is a long one. Your patient, the glomerular diseases, the nephrotic presentation, and the nephritic presentation. As you'll see, minimal change, membranous, focal segmental. Most of the time, they are having nephrotic presentation. You don't have gross hematuria. IgA nephropathy share both. It may be nephritic, nephrotic. Membranoproliferative usually will be nephrotic, nephritic. Crescentic GN, mostly nephritic presentation. So really, this makes a lot when you look about your patient history, when you are taking that history. So that's basically, we'll stop here for a minute if there is any comment from Ala, from Safa, before we proceed to the cases.
شكرا جزيلا أستاذ. This is a very great comprehensive review, and to have wisdom, you should have the defining terms, and these are the defining terms for any nephrologist, and especially those who are dealing with nephropathology. استغل الفرصة وأرحب ببعض الزملاء والأخوة الأعزاء من الأردن مع أستاذنا دكتور رياض، دكتور رولا، دكتور همام، واهلا وسهلا بهم، يعني ضيوف اعزاء على الجمعيه العراقيه لامراض وزرع الكلى. اذا
الدكتوره رولا عراقيه الاصل.
تشرفنا
وهي
اهلا وسهلا بها وبحضرتك. اذا في من الشباب اي question so you can write it on the chat. اذا ما في we can go حتى ايضا نكسب الوقت، يعني
اللي انتم عايزينه.
يعني أنا لحد الآن مدى أشوف أي سؤال،
يعني مفهوم الأمور إن شاء الله.
لأنه أستاذ يعني you just simplified everything and you put everything according to the physiology and pathology, and this makes the basics to understand nephropathology. أعتقد نكمل أستاذ، بس ردت أستاذ أسأل حضرتك بعد كل كيس إحنا ممكن نخلي فد إذا في مجال يكون أكو سؤال أو discussion.
نعم موجود.
حاضرين.
We'll do it interactive session.
Excellent. Go ahead, sir. Go ahead, please.
I have to take this away, this picture. Okay. Now, our first case. This is a recent history of decreased urine output, rising serum creatinine, accelerated hypertension. So that's basically the title of the case. Our patient is a 58-year-old gentleman, hypertensive for 5 years, well controlled on both calcium channel blocking agent and beta blockers. He's a chronic user of non-steroidal due to this problem. He's not diabetic, but he's an ex-smoker. Blood pressure out of control in the last 2 weeks, 190/110, requiring more medication without achieving any benefit. There was no significant change in his lifestyle for the last 1 year, and no other medication were added in the recent past. He's middle-aged, anxious, but not in acute distress, hypertensive, heart rate 72, his weight is 68. Apart from mild puffiness of the eyes and 2+ lower lymphedema, his physical examination was entirely normal. His hemoglobin 13.5, white count is acceptable, platelet good, ESR 45, normal PT-PTT. Creatinine 3.2 milligram per deciliter and increased in front of us 3.9 and 4.6. Sodium, potassium, calcium, phosphorus, all that really looks good, except his albumin was on the low side. Now we look about his urine. He has 3+ proteinuria, RBC 640 per high power field, protein creatinine ratio 4 gram almost. He has red cell cast in his was negative. So we have a patient with abnormal kidney function, hypertension, hematuria, proteinuria, and red cell cast. That's just to explain the red cell cast. Summary, 56-year-old gentleman, hypertensive for 5 years on treatment. Blood pressure is out of control, associated with rapid worsening of kidney function, findings suggestive of acute GM because of the RBC casts. Now, that's when we approach this patient. Acute kidney injury, if this on top of chronic, possibly, hematuria, proteinuria, nephritic urine, rapid rising serum creatinine. There is history of non-steroidal abuse. We have to keep it in mind. Is acute GN, mostly RPGN? Is it ANCA related? Is it IgA related? Is it post-infectious? We don't know. Or it's drug-induced interstitial nephritis. Any question here at this point? Any thoughts? علاء زميلنا
دكتور صفاء أي واحد من الشباب. So we are dealing with acute worsening of the renal function with RBC cast in a middle-aged male with history of use of non-steroidal anti-inflammatory drugs. أحد الشباب he suggested ANCA-associated vasculitis.
Okay.
Any other suggestion? دكتور صفاء.
يعني انتظروا الطلاب، هذا تيتشي كورس، انتظروا الطلاب خلينا يحشون بعد، اريد اراء مال الطلاب.
Another
one suggested the drug-induced interstitial process.
So basically they are in agreement with what we have.
Yes.
ANCA-related, IgA, nobody mentioned IgA. Okay, post-infectious. Okay, let's proceed and see what we have.
Okay.
So, is it someone advised about interstitial nephritis? Do we see cast, RBC cast in interstitial nephritis? This patient has red cast.
لا.
And this
is
classical teaching, RBC cast should not be seen in interstitial nephritis. That's a classic teaching.
That's a classic, but it can occur. Look about this. There are this article here in 2012, 6 out of 21 patients, nearly 30% with biopsy proven acute interstitial nephritis in one study had RBC cast in the other. So it can occur, but the classic teaching, this is acute GN. We used to say it's pathognomonic of GN.
Yes, sir. Yes, sir.
Now, what other test now you want order for this patient with acute GN?
Some suggested to go for complement testing, C3 and C4.
Okay, let's see. We have hepatitis, which is negative, always we will do it. C3, C4, here we are. 125 normal, 19, we are thinking on the same line. So at least we ruled out post-infectious, we ruled lupus, we ruled out
great.
We ruled out cryoglobulin. So both really we are dealing with could be anti-GBM, IgA, ANCA-related. So all these complement normal diseases.
Exactly.
Okay.
Okay. Now here is NA. We know it's going to be negative because complements were normal. ANA less than 100, anti-DNA is less than 110. So because the complements were normal, lupus did excluded. And then we have anti-GBM antibody, it's negative. ANCA, both C and P were negative. So again, we are thinking.
Ustad Riyad, they should learn that Ustad Riyad will not present the usual case that you can diagnose easily.
Okay. Thank you.
Okay, Ammu. Ustad Riyad will not present the case. He wants your brain to work out, okay?
We need to
اللي هو
brainstorm.
عمو أنا هم طالب هسه الله يخليك يعني ما أقدر أوصل لمستواك بس we will try to just to cope with it, okay عمو? Okay, عمو.
And then so serology, that's what we have. ANA negative, anti-DNA negative, hepatitis B, C negative, complements normal, ANCA, anti-GM negative, and his parathyroid hormone 103, which is up from normal, and we know possibly there is acute on top of chronic. So, what's your next step? We are in a pathology session. I'm sure
definitely will go for biopsy.
Now, pending that this patient's kidney function, we'll proceed with this. We don't need really to talk about management now.
Okay, okay.
We did the kidney biopsy. 14 glomeruli on the light microscopy, 9 glomeruli in the immune fluorescence. And that's the kidney biopsy as you see in the intense interstitial infiltrate on the light. On this is lower magnification. There's some widening between spaces within the tubules. This glomeruli here, and that's sclerosed. We'll go to higher power. As you'll see here, there is good interstitial diseases because the tubules, normally they should be tucked together. There is no space in between. So that indicates there is a process of fibrosis. All this is collagen. And we see this glomerulus here. We see the blood vessel with thickened wall. Let's go to higher magnification. This is the glomerulus. See it good, the capillary loops, basically you don't see it, it's closed, and you start seeing a crescent. This crescent here is forming here. With normal basement membrane, we can't really talk about it because it's very difficult with this kind of infiltrate and disease mesangial process that you have. It's another glomerulus here, capillary loops, and this periphery looks fine, but this part there is another crescent present in this patient. That's sclerosed glomerulus. This is what we are talking about, tubules interstitial disease, which looks fibrous tissue most of the time. Tubules are widely separated, and these are not really edematous tissues. Here we come to a large area of interstitial infiltrate that was present, which is mononuclear cells, some plasma cells, and there are some eosinophils that you are seeing.
No, eosinophils are clear, sir. Eosinophils are clear in the specimen, yes.
Okay, there is one eosinophil here, that's one polymorph, that is plasma cell. So some eosinophils, as you'll see. And this is here under PS stain, as you'll see, this glomerulus is with circumferential, almost crescent formation. Again, that's crescent. So what we have in this biopsy, just because summary, 3 total sclerosed glomeruli out of the 14, 9 of the 14 cellular crescent with accentuated lobulation, increased mesangial cell and matrix, focal necrosis with few neutrophilic material, capillary membranes are not thickened, and significant tubular atrophy, significant interstitial fibrosis, as I alluded to, and blood vessels are markedly thickened. So we have, if you have 9 out of 14, that's more than 50% of your glomeruli are affected with crescent. So this is crescentic GN. Now, RPGN now on top of chronic disease. Now, as I mentioned, when we have RPGN, is it linear? Is it immune complex or pauci-immune? So our next step will be what? What your staff will ask for.
So what will you ask the pathologist for opinion? You just have the light microscope, and then you should go for the second step in evaluating a renal biopsy specimen. So we will go for immunofluorescence or immunohistochemistry, and if it is not resolved, we will go for EM.
Okay. So let's
EM.
EM. Well, I think, as Ala mentioned, we'll go gradually. Not every place has EM. We have in our facility, light microscopy, immune fluorescence. We can have it really on the same day, next day of the biopsy. So that's, I put here linear for you. And then don't forget, also we have mesangial granular deposit sometimes. So you have type 1 linear, you have type 2 both, which is granular capillary, granular within the mesangium, and the pauci-immune. So our patient, that's his biopsy.
Yeah.
So sir, can I ask?
Yes.
In such age, a patient is 56 years old male, and when we are going for immunofluorescence, we may ask also not for the IgA, IgG also, but can we ask with his age and his symptoms about the staining for free light chain in such age? Kappa and lambda.
It is routinely in our lab, we'll do light chain staining.
Yes,
Kappa
sir.
and
yes, sir. Thank you.
Yeah.
Okay, we do it routinely.
So it's not a linear.
But this is mesangial deposit.
Mesangial deposit.
Yes, mesangial deposit,
Yes.
which is classic of IgA nephropathy.
IgA nephropathy, yes.
Classic of IgA nephropathy.
IgA nephropathy, أستاذ رياض. It's not linear and it's mesangial only.
It's mesangial.
Mesangial only, yes, sir. Mesangial only.
Yeah, it's mesangial. The capillaries are on the outside. That's in the mesangial.
Yes. Very interesting case.
So what we have immune complex crescentic GN, IgA nephropathy, significant tubular interstitial component.
Yes. It can present with IgA vasculitis, with or without skin lesions. And it can be settled like this chronically. Yes, I see the.
Now, anyone with this background retrospectively would like to go and ask the patient about a history.
Yes.
There is history suggestive of anything.
أستاذ طبعا the most common cause of glomerular disease is IgA nephropathy, and it is increasingly recognized as the most common cause, one of the common causes of unrecognized or undiagnosed end-stage disease. Many cases passed into end-stage disease without biopsy, and then they will discover the IgA probably with recurrence in the graft. We should probably return to history if there is any history of symphalangitic hematuria, a relation of hematuria or discoloration of the urine to the any response to inflammatory state like that of the upper respiratory tract infection.
I put for you this slide. Here is the slide.
Okay.
History of recurrent episodes of gross hematuria for the last 25 years, following upper respiratory within 24, 48 hours and last for 2 to 3 days.
عشان في دكتور.
أستاذ رياض، أنت عندك مريض دزيت لي إياه للمتابعة which was an advanced IgA which was put on mycophenolate. Interestingly, he has no history of even hematuria with upper respiratory tract infection. So it was very interesting. تذكر أستاذ رياض.
Which is basically worse, يا صفا.
Yes.
Current microscopic hematuria, they have a better prognosis than the ones really they don't, because they may have persistent microscopic hematuria.
Yes, yes, sir. Very interesting, أستاذ رياض. Very interesting. عاشت إيدك.
Okay. So this is basically the patient. So how are we going to treat this patient الآن? How to treat this patient?
Any data من الشباب؟
اكو آراء على السؤال مال أستاذ رياض؟ اكو آراء أي واحد يقدر.
Treatment of rapidly progressive GN with a biopsy diagnosis of a crescentic IgA nephropathy on a top of a chronic damage. طبعا الشباب اكيد عرفوا انه استاذ رياض بدا اوريدي بلس ستيرويد
شويه.
تفضل عمو صفاء.
ايه صفاء.
استاذ رياض يمكن. نعم استاذ رياض. اكيد the last thing about IgA nephropathy that was mentioned in the literature is the Stop IgA nephropathy trial. أهم شيء كان موجود بهالترايل هاي إنه conservative treatment has been effective in 34% of the patients. That was protein restriction, ACE or IRB plus conservative treatments. That was the main result of the IgA nephropathy or the Stop IgAN trial.
The problem for crescentic GSM.
Yes. In this trial, there was no crescentic GN. But in the literature, what's mentioned that crescentic IgN should be managed according to the guidelines, like other rapidly progressive GN. That's to say, cyclophosphamide steroids should be given if the histopath suggests that it was a cellular crescent, not fibrosed one.
You have to remember that until recently, the classification, Oxford classification, classification, was not really including crescent. Now they start adding C.
Yes, yes, sir. But it was, C was added at the end.
That's
C
true.
was added, Amr Riyad, for the chronicity.
Yeah.
Must C must C was added for the chronicity.
No, crescent.
Yes.
They added crescent to the classification.
So for that reason, I think that steroids and cyclophosphamide should be added for this patient, at least to halt the activity of his process.
So his kidney function is deteriorating in front of our eyes.
Yes,
let's see what we have in the literature.
But the problem of chronicity that makes that alkylating agents is of a question mark on this patient. Probably steroids only is the only hope for this patient, sir.
Sir, in the last few years, there are increasing reports about the use of rituximab in treating crescentic IgA nephropathy with advanced renal impairment, and especially with the risk of getting severe infection from the use of cyclophosphamide. Most of the reports are very anecdotal, but there are case report and case series. So probably this patient may benefit from it. So we are looking for your expert and wise decision.
Okay.
So
let's
please.
see now. Renal biopsy, when you see a patient with microscopic hematuria kidney injury, kidney biopsy should be done in 2 to 3 days with supportive measures. Two things you may have really in a kidney biopsy with IgA nephropathy, no crescent at all. What you see is RBC, the kidney biopsy full of blood, red cell cast there because of the hematuria and the hemosiderin that can cause acute tubular injury. This kind of tubular injury will recover. We have a good number of such patients.
Yes, it's iron-mediated.
That's true. So this is supportive care. This is supportive care. Here you have to worry about your management. Now, tubular necrosis, supportive measures. Here, crescentic IgA may be appropriate immunosuppressive therapy. Now, the most difficult cases to treat with RBGN is the IgA nephropathy.
Yes.
Look about type of RBGN, renal survival. That's from Dan Feely when he gave us a talk 2012 in Amman. Systemic vasculitis, like ANCA-related, which is really very good result. 1 year survival, 5 year survival. Goodpasture syndrome, 70%. 1 year survival, 5 year survival, 50%. Look about IgA. 1 year you are talking about 50 and 5 years 20. So really, no matter what you do, the outcome is not really the best. Now, steroid has been tried, small studies, as we mentioned, anecdotal steroid therapy with cyclophosphamide. And for our patient, what we did, we gave him steroid pulse therapy, we gave him IV cyclophosphamide. Look what happened, that's where we start here. His creatinine 2.5, 3.6, 3.9, 4.5. We decided we have to treat this patient, and we followed him, and you see his kidney function gradually improved to baseline. So he continued on oral prednisone and oral cyclophosphamide. His hemoglobin is holding, urine protein continued to be on the high side, and that's his baseline basically after a couple of months of therapy. So there is a room. You can really, it's an open discussion, but definitely plasmapheresis has no role. Rituximab, yes, has been tried, but the results are not really so far. We don't have a large data.
مثل ما قلت عمو رياض, cyclophosphamide steroid should be given in this patient. Yes.
علاء.
نعم أستاذ.
What do you think?
أستاذ, this is the usual management plan and strategy for any patient with the crescentic GN, no matter what's the pathology underlying it. The most important and the most serious issue is that those patients with IgA, they didn't, مثل ما قلت حضرتك, these are very report from old data. They usually succumb into CKD and end-stage renal disease very frequently, and because of the use of many immune suppression, they may pass into state of recurrent infection. This is the serious issue. It is unlike those patients with NK-associated vasculitis that may be maintained on cyclophosphamide or azathioprine with good response. The crescentic IgA is a very challenging issue, and we recently published a case with a crescentic IgA recurrence post-transplant. The patient lost his graft and died because of severe acute renal failure. It is almost always a grave presentation. So if your patient start to get his renal function, this is an excellent response.
Okay, let's move for the second case because we have...
Riyad.
Yes.
Riyad, what about after a second or third cyclophosphamide or of re-biopsy the patient?
Well, it's difficult really. We know that he has some chronic kidney disease.
Yes.
I think we managed the acuteness with the blood pressure and all that. It all was really GN related.
Yes, sir.
Okay. Now, this patient here, acute kidney injury, in a patient long-standing history, non-productive cough, shortness of breath. Someone may have an answer now. Caucasian male, impaired kidney function with mild hypercalcemia. History, non-productive cough for the last 12 months. More recently, general fatigue, exertional dyspnea, but no hemoptysis. He has nocturia 2 to 3 times for the last 6 months. He's not diabetic, by the way. History of well-controlled hypertension for 2 years. Ex-smoker on allopurinol, amlodipine, different courses, antibiotic for chest infection, no non-steroidal use. His weight 65 kilos, blood pressure is acceptable, mildly dehydrated, good entry bilaterally, occasional wheeze, cardiac, abdominal examination, normal, no edema, peripheral pulsation. Urine analysis, 1+ protein, yes, hematuria, white cells, 50 RBCs, no cast, urine culture negative, spot urine protein creatinine almost 400 milligrams. So there is no hematuria, very little, but some element of proteinuria. Normal hemoglobin, he's a smoker, serum creatinine 2.8 milligram, total protein 7.2, albumin 3.8, calcium 12 milligram per deciliter, and parathyroid hormone 25. So it's not hyperparathyroid related hypercalcemia. So serology, we have it all negative, and his R is 75, normal ultrasound by sizes, chest X-ray, prominent hilar region, and what's the most likely diagnosis? The patient with hypercalcemia, impaired kidney function, shortness of breath, history long-standing of cough, and mild proteinuria.
Okay, Ustad Riyad. يعني the history, can I comment now?
Yes,
قبل ما عم صفاء يسوي comment, most of the younger nephrologists suggested sarcoidosis as the main diagnosis. Dr. Safa, please.
Go ahead.
Ustad Riyad, the finding of this, يعني it's a mild hypercalcemia with a prominent hilar lymph nodes, a middle-aged man with acute kidney injury probably points to the diagnosis of sarcoidosis, Ustad Riyad. Sarcoid.
I think seems to be we are in agreement.
Yes, sir.
So far, I put this just, in between cases. Now, what other test now the young chaps they want?
Serum ACE level.
That's what you want or what they want?
They accepted the idea of using ACE level to assess for the presence or absence of sarcoidosis, but it is mainly for the diagnosis of disease activity. Definitely, we need a pathology diagnosis, but the classical history and the presentation is highly suggestive of sarcoid, and so our young fellows are suggesting to go for ACE level.
You have it.
Yes, I see.
That's high.
Okay. Now, what sarcoid with acute kidney injury? What's the differential diagnosis now? The young chaps, what they think?
Yeah, the young chaps should suggest hypercalcemic acute kidney injury first. Second, probably an acute induced by the granuloma itself in the kidney. Riyad, حمد سوي هيجي. يعني yes, hypercalcemia induced acute kidney injury. This is first. Second, probably acute tubular interstitial nephritis induced by granulomatous lesions of the sarcoid itself.
Okay, so we have hypercalcemia,
Yes.
and we have granulomatous interstitial nephritis, and we have sarcoid-related GN.
GN, yes.
Okay, there are categories sarcoid-related GN.
Yes.
Now, how we differentiate between both sarcoid-related GN and granulomatous interstitial nephritis, possible hypercalcemia also?
The serum calcium level is not so high in this
Well,
patient.
we are excluding that now. We're
Yes.
talking about how we
So
tell the
see, we are in need for pathology diagnosis to
Yeah,
confirm
Yes.
that it is a GN related or it is a tubulo-interstitial process.
Okay, well,
Yes.
we look about the urine analysis, just simple urine analysis. We have benign looking urine sediment apart from the white cells. We have no casts. We have sterile biuria. We have around 400 milligrams. That's most likely not GN. That's most likely
It's a
tubulo-interstitial process.
tubular interstitial disease. Yes.
Okay, with the mild hypercalcemia. So it looks really like we are dealing with tubulo-interstitial disease
Nephritis.
more than glomerular disease, but it can occur. Now, sarcoid-related GN. Now the next step is biopsy. We have 14 glomeruli on the biopsy, 9 on the immune fluorescence, and that's the biopsy here. We have that on light microscopy. We can tell that there is some abnormal findings.
Yes.
Here, there is a lot of interstitial fibrous tissue present. And if we look at higher magnification, again, there's some interstitial infiltrate present here. That means chronicity of a disease. Look how widely the tubules are separated from each other.
Yes, separated. Yes,
Okay,
sir.
with this interstitial infiltrate present here. And so far, we didn't see much glomeruli. Now here, we look about this part, it looks fibrous tissue also. That's one glomerulus, second glomerulus, but you have interstitial, that's another glomerulus, but you have scattered thin, intense interstitial infiltrate with this. This is one glomerulus here we have. It looks normal looking glomerulus. Capillary loops are patent. Look about the mesangial cells are not increased, but there is a good periglomerular fibrosis. All this surrounded by intense interstitial infiltrate. Look about the eosinophils.
Yes.
Aku eosinophil start Riyad.
Yes.
Scattered eosinophils in the interstitial. There is scattered eosinophils.
Okay,
Yes, sir.
you have it here.
Yes.
And that's another glomerulus, which looks perfect. Look about how nice the basement membrane, the capillary, the cells, the mesangial cells. So that's a normal looking glomerulus. So we don't have glomerular disease in this patient. And that's the interstitial area, which is the infiltrate that we have. Under PST, perfect looking glomerulus.
Normal.
That's sclerosed glomerulus, which is really by virtue of age, we can have 1 or 2 sclerosed glomeruli. This is the interstitium. Infiltrate, plasma cell, plasma cell, plasma cell.
Yes.
So this patient, though he denies the use of non-steroidal, but there is something there here. And then we come to this section of the kidney. This section of the kidney, basically it's being replaced by some structure that really does not look like a glomerulus or renal tissues. And higher magnification, we came to this. What's this is Ala? That's not a glomerulus.
Yes. This is the interstitium with non-caseating granuloma.
This is granuloma. That's a granuloma. Look, this is all this granuloma. Okay, non-caseating granuloma with the interstitial surrounding. This is, we are lucky to find this, which is unusual to find it except in sarcoid. That's what we call it, Schumann's body, Langerhans giant cells.
Yes.
We were lucky to find it in the biopsy. These are calcification within the inner tubule, and that's really the Langerhans giant cell. Okay. And that's another granuloma.
Yes, sir. Yes, sir.
So we have Zinn-Nelson stain. Each time you see granuloma, you should stain it for AFB. So we have 14 glomeruli, non-casadic sarcoid-like granuloma, pronounced interstitial infiltrate, xenil sustain negative, immune fluorescence studies negative, all of that. So our final diagnosis, sarcoid-induced interstitial nephritis.
Yes, sir.
Sir, the patient didn't give history of eye or ear involvement?
Answer Dr. Ala question.
You can start the Riyad, what's described previously about uveo parotid fever. These are the acute presentations that we do not see in our areas, sir.
Dr. Ala is asking about any history of eye involvement.
Because this is the sometimes one of the, although sarcoidosis is not common in our area, but it is usually linked to a classical presentation of acute tubular dysfunction with TAINU. It is uveitis and tubulointerstitial nephritis. Some patient doesn't present with such aggressive deterioration in the renal function, but they may just present with deterioration of the tubular function with electrolyte disturbances and uveitis and eye or ear involvement. So this is maybe the initiating symptoms that we should raise our suspicion that the patient has a sarcoid interstitial process.
Well, that's true. Tineo, you are talking about tineo,
yes, sir.
Interstitial nephritis with uveitis. Now,
it's a primary disease, but I don't think that in Tainu we have granulomas. In Tainu, it looks like an autoimmune process that involves young females with the primary uveitis, with interstitial nephritis, but granulomas are unusual in Tainu syndrome, sir.
Okay. So, this patient hypercalcemia with hydration, steroid therapy. Steroid is the mainstay of therapy for such patients. 2 weeks later, his proteinuria decreased to 150, serum creatinine decreased to 1.3 from 2.6, calcium normalized, albumin, hemoglobin, ACE level dropped to 35. Prednisone gradually being tapered till the patient stayed on 20 to 30 milligram daily up to 6 months for his lung disease. Yes, so that's this. We're not going to go through a lot of sarcoid. I think we discussed this, but I have one thing about tineo here. A retrospective study of 40 cases renal granuloma. When you see this, your differential diagnosis, 20% of them were sarcoid. So really, sarcoid is the commonest cause of granulomatous interstitial disease. Another drug-induced. And that's really, I kept asking this patient about medication, especially with the high prevalence of eosinophils that we found in his kidney biopsy. TB, Wagner, by the way, we diagnosed the patient with Wagner granulomatosis with kidney biopsy. I think I have him presented later on. Leprosy, Mycobacterium avium, Khan syndrome. All these really can lead to granuloma. Tineo, as Ala just was talking about, urinary manifestation, ground interstitial nephritis, relatively non-specific. Urine analysis typically of chronic interstitial disease, normal showing only sterile biuria. You have to remember sterile biuria is indicative of what we have. Any question about sarcoid?
عشيدك استاذ رياض.
Okay. Any question about this case before?
No, sir. You can go for the next case.
Okay. The third case is a 58-year-old male patient admitted to Jordan Hospital. Evaluation, moderate renal functional impairment and severe anemia. 6 months history of back pain and progressive fatigue with frequent use of painkillers. 2 months later, prior to admission, notice swelling of the lower extremities, difficulty in urination and nocturia 2 to 3 times. He was told to have impaired kidney function for the first time. No history of hypertension or diabetes. Middle-aged individual, he looks sick, in pain, extremely pale. normotensive, he's dry, wasted, temples, and no lymphadenopathy, chest cardiac examination normal, abdominal examination showed mild splenomegaly, otherwise normal, lower lymphedema, severe tenderness over the lumbosacral spine, and he is unable to walk. His gait is difficult to walk from his basically vertebral column trouble. When we saw him, his hemoglobin is 5.6, platelets addictive. Look about his ESR, 130, 180, anemia, severe, very high ESR, creatinine 4.5 milligram per deciliter, calcium normal, phosphorus slightly up, low protein, low albumin 2.9, with serum protein 6.8, liver enzymes normal. So we have anemia, high ESR, abnormal kidney function, normal otherwise. Urine analysis, few red cells, 1+ protein. Look about his proteinuria, 7.5 gram. Serology, all negative. I'll stop here. Any thoughts from the young chaps?
So for all our young fellows, we have a 58-year-old male, severe anemia, chronic back pain, unable to walk, hypercalcemia, renal impairment, high
Calcium is
ESR,
normal, Ala. Calcium is normal.
9.2.
Maybe slightly up, maybe slightly up. Albumin 2.5.
And with the proteinuria. So they already start while you are talking حتى يعني prior to presentation of the laboratory test, most of our young colleagues, they suggested that it is a case of multiple myeloma. But with this protein creatinine ratio of 7.5 gram, we should think beyond multiple myeloma and beyond.
Okay, I like beyond. So far, that's what we have. Okay, now to summarize, 58-year-old patient, 6-month history of back pain, hemoglobin high, creatinine, proteinuria 7.5. I'd like to attract your attention now to our colleagues that when you see protein, our dipstick detects only albumin.
Yes.
Detects albumin. But the method that we measure, turbimetric method or just actual chemistry, detects both protein, all protein, albumin, globulin, all kinds of proteins. So when you see discrepancy between the dipstick that's basically 1+ or negative, and you have a heavy proteinuria, think about flooding the system, light chain proteinuria.
Yes.
Light overproduction, something being produced, non-albumin proteinuria that's coming down in the urine. So what's the next step of differential diagnosis? I think any test now you'd like to order now?
What
Did
test?
they ask about anything? Single test. How they proceed?
Our young fellows, they are suggesting testing for light chain.
Okay, well, before light chain, what about serum protein electrophoresis?
This is the first step, and then to go for light chain assessment.
Okay, so this is the serum protein electrophoresis. It looks basically, that's alpha, that's albumin, alpha 1, alpha 2, beta, and you see about the gamma region. There is nothing in the gamma region.
Yes, exactly.
There's nothing. So it's not typical myeloma. Yes. We don't have the monospike.
Exactly.
So if we think about myeloma still, it has to be something different, that we don't pick it with the normal serum, with the serum protein you should have urine protein electrophoresis, because you may have substances here in this region, all of it coming down in the urine, i.e. light chains.
Yes.
So they need to have immunofixation, which is for light chain. That's what they requested. And they have 24-hour urine collection, IgE kappa monoclonal band 1.6 gram, and urine for kappa lambda ratio 2.3. So we are on the track that we are dealing with light chain deposit disease, light chain myeloma. It's called light chain myeloma.
Sir, prior to go for further investigation, I would like to have your opinion and definitely your informative explanation to our young colleagues about how much the renal function is affecting the ratio of kappa to lambda. The patient has impaired renal function. It is not the usual renal function.
Yes.
Does this affect, does this low GFR affect the rate of urine kappa to lambda? And does it affect
ideally,
the
if we can have
excretion?
serum, I think ideally if we have or lambda in the serum will
Yes.
be more advisable. Yes.
Yes, exactly. Thank you, sir.
This is the skull of the patient.
Classical osteolytic lesions, Mr.
These
Riyad.
are punched, clear out lesions.
Yes.
Okay.
Osteolytic.
And then we did bone marrow. That's a bone marrow. Sheets of plasma cells. Plasma cells all over. So bone marrow, plasma cell dyscrasia. So 68-year-old patient was found to have anemic, very high ASR, destructive bone lesions, abnormal serum protein electrophoresis, heavy proteinuria, and bone marrow is this. Then we need to have a kidney biopsy. Then this is pathology.
Yes, sir.
Okay, we have 18 glomeruli on the immune light, 7 on immune fluorescence. That's the kidney biopsy. It's we have more than 19 glomeruli, and that's here you start seeing 1 glomerulus, 2 glomerulus, 3 glomerulus. And look about the renal tubules. The renal tubules are not really bad, so very little interstitial disease. They are almost close to each other in this area. And look about this, look some abnormality in the glomeruli.
Yes.
Under higher magnification, see what we have. These are nodules, nodular pattern of glomerular injury. You have to remember, nodular pattern, we have diabetes, we have amyloid, and we have
light chain deposit
disease, DIMM, okay? And that's more important. Look about this, it's exactly the same. Increased cells, there's cellularity. The capillary loops are not that bad. You may see some mesangial matrix expansion, and you see cells, variable number of amyloid, you don't have cells. Diabetes, you don't have cells. Here you have abnormal cells present. Here it's crystal clear that you are dealing with nodular pattern of renal injury. Talk about this nodule.
Yes.
Now, PS stain, this material, when you see this, it's quite pink. It's not really amyloid.
Yes.
Amyloid will be faint looking. Amyloid will not stain the Bowman's capsule.
The tubules also.
Stain the renal tubules. All this, the renal tubules, the Bowman's capsule, with this kind of stain, with this pattern, that's not amyloid. This is deposit disease, light chain deposit disease. Now,
yes,
this is, we stain them now for kappa or lambda.
Yes.
This is the kappa, which is the brown stain looking here. It's strongly positive. That's kappa. Look about in the basement membrane, the Bowman's capsule, basement membrane of the tubules, and within the mesangial deposits. This is lambda. It's negative.
Yes, sir.
This is lambda, and it's negative. That's lambda. It's negative. What you have, basically, immunohistochemistry, deposit of glomerular mesangium, Bowman's capsule, some tubular basement membrane, deposits were positive staining for kappa light chain, negative for light chain deposit. So it's kappa disease. Yes. Monoclonal immune deposit disease, light chain, kappa type. That's our differential diagnosis, and that's our pathology. Now, any thoughts how you're going to treat this patient?
Sir, prior to having a treatment strategy, do you suggest testing for with other imaging techniques like PET CT, for example?
No, we did not really.
Yes, because the bone marrow is a classical of plasma cell dyscrasia. If the bone marrow is not suggestive, for example, with inadequate number of plasma cells, we may go for such imaging state to exclude other pathology in the reticuloendothelial system. What's your opinion, sir?
Well, we can have in that staining, you know, the pathologist can
CD138 and CD54.
Yeah, we have that. I think that routinely can be done. Yes.
Yes, sir. Yes, sir.
Our pathologist will do this routinely, but really, I'm not a pathologist who say. But definitely, yes, that's part of our protocol, looking for the different kind of cells based on its immunohistochemistry.
Yes, sir. So, any suggestion about the treatment plan? Yeah, Shabab?
Yes.
اتذكر باخر امريكان سايتي اوف نفرولوجي حضرنا الجلوميرولار ديزيز انا وحضرتك سويا. There was a great talk about whether the hematologists or the nephrologists should treat those patients.
We are, by the way, we are seeing more cases.
Yes.
Multiple myeloma more than the hematologists.
Yes.
We diagnose them and
yes, in that lecture, I think that he divided the patients into 4 categories. 2 of them concerning the nephrologists and 2 of them concerning the hematologists, sir. What's mentioned before, that monoclonal gammopathy of unknown significance is changed now to monoclonal gammopathy of renal significance, sir. So I think that there is an aggressive bone marrow involvement in this patient. This is one. Second, there is a systemic evidence of the disease with the kidney involvement. So I think that there should be a cooperation first by the hematologist for this patient and second by the nephrologist for this patient, according to the ASN classification. That migraine monoclonal gammopathy of renal significance can be treated by a nephrologist, but with this systemic involvement of bone marrow, the kidneys, and probably subtle involvement of other organs, that this patient should be treated by chemotherapy by the hematologist, and he should be followed up by the hematologist, sir.
Let's see what the literature really says. Data on treatment of light chain deposit or heavy are limited. Therapeutic approach usually similar to those employed patients with multiple myeloma, and that's why the hematologist really goal to control plasma cell proliferation disorder to preserve renal function and improve survival. Chemotherapy, plasma exchange, autologous hematopoietic cell transplant, and that's basically what serial-free light chain assay can be used to monitor response of therapy. Free light chain in the blood. That's what asked about. Look about the list of chemotherapy. It's ridiculous. It's ridiculous. Combination, different combination. Steroid alone, melphalan steroid, melphalan cyclone, melphalan rituximab, and dexamethasone, melphalan thalidomide, and it's an endless protocols. So really, that's why I rather personally not deal with this kind of protocols. We leave it to the oncologist. I'm sure you do the same thing.
Sir, the International Myeloma Working Group have suggested a treatment plan. They are going for more bortezomib-based therapy. And there is an international monoclonal gammopathy working group. Has been led by people from Mayo. They are more going for bortezomib-based therapy. We have a few patients through the collaboration with the hematology. They suggested that the early presentation with aggressive renal impairment, it may indicate to some extent good response because good response to bortezomib. الآن الرول of melphalan is decreasing. Now they are going for bortezomib, lenalidomide, carfilzomib, and other new modalities.
Yes.
فيمكن لأنه
I put for you here the list.
Yes,
which
sir.
is bortezomib,
عمو رياض عمو رياض أنا عندي مرضى مايلوما وLCDD من حولت على الهيماتولوجيست دكتور أحمد خضير المشهداني. When we started Melphalan, it's a very simple drug, although it's a bone marrow toxicity is high.
Yes,
it's an old one with low price. It can be given orally on every 4 to 6 days. All of them, يعني 2 patients with Melphalan and steroid every 4 to 6 weeks, they will an excellent
I'll tell you
results.
what we'll do. Before the patient being seen by the hematologist or oncologist, we already treating them with steroid.
Yes, sir.
That's
Yes, sir.
in order for that's basically with Dexa or steroid therapy, and then they will come, they will continue.
Yeah.
I'm sure rituximab, and also it depends upon bone marrow transplant priorities. Yes, they have special classification techniques.
Yes, sir.
Okay, how we treated our patient. Now let's see. This patient, we treated him with prednisone and we did plasma exchange for him.
Yes.
Nobody mentioned plasma exchange. And then he received also rituximab, as you notice here. So prednisone, plasma exchange, rituximab, supportive treatment, blood transfusion, diuretics, painkillers. Symptoms improved, moderate renal functional improvement. Creatinine came down to 2.5. There are some chronicity. He was really referred for autologous hematopoietic cell transplantation.
Sir, there are 2 conflicting reports about the use of a plasma exchange or the use of high flux membrane dialyzers for those patients with very high titer of the light chain. Some data suggested that a plasma exchange may be useful, and I think your plasma exchange strategy did well because it went to the exact needed plasma volume. Most of the plasma exchanges in such cases, they don't reach such plasma volume, and that's why they suggest that they may be not so beneficial. So this is very important. The other point, I would like to have your opinion. If this patient pass into a state of end-stage renal disease, do you suggest combined kidney and bone marrow transplantation?
Well, I'm not sure really about this. We'll see what the hematologist they feel. Once really the patient is in end-stage kidney disease, I don't think that really it will matter what you're going to do. Yes, you can transplant them, okay, but which will come first? Autologous, bone marrow, wait after that until he really will take off his bone marrow, then you transplant him. That's the way that I'll do it.
عمو رياض.
Yes.
بالنسبة للplasma exchange, still it's mentioned for acute myeloma cast nephropathy when the burden of the protein of the tubules is very high.
That's true.
Yes. يعني when there is an acute myeloma cast nephropathy, plasma exchange is mentioned just to lower the burden of these abnormal proteins on the tubules. Plasma exchange, sir, it's okay. You can do it even for LCDD, عمو رياض. But kidney transplantation for a myeloma, for the classic teaching, one of the most popular contraindications to kidney transplantation is myeloma. أستاذ رياض. يعني this is the classic teaching. There is some case reports. David Sachs was tried in 2014 and he reported 7 cases of combined bone marrow and kidney transplantation with various results. Still, the combined bone marrow and kidney transplantation is a matter of research. No one can do it with a secured results, Stavria.
It's not easy. It's never easy decision.
No. Yes, sir.
Okay, sir.
Any question about this case?
No, sir. Go ahead. Go ahead, please.
Okay. Now the other one, again, 30. This is an 83-year-old gentleman. 83. Referred to Jordan Hospital evaluation, recent onset of acute kidney injury that required renal replacement therapy. The patient history dates back nearly 2 weeks prior to admission. Bilateral severe flank pain, moderate severity without radiation or any fever. This was associated with oligoanuria. The patient received medical advice and he was given non-steroidal for his pain without any relief. He has local treatment by Hujama, طبعا, was performed. I don't know whether you have it in your area. I'm sure you have it, Hujama هذه.
Yes, sir. Yes.
He's hypertensive but not diabetic. Patient noticed a gradual decrease in his urine. He became anuric within 48 hours, no gross hematuria. Was admitted to other facility injury, creatinine 3.5. Progressive worsening of kidney function, creatinine reached more than 7. Required hemodialysis support through right IG dialysis catheter. 3 days later, transferred to Jordan Hospital for management, and just our nephrologist who transferring him, they were scared to have a kidney biopsy on an elderly male patient. They said, well, can you do it please for us? I said, send him, we're more than happy to do that. His medication, calcium, 1-alpha amlodipine. Physically, elderly patient, not in acute distress. He was pale, hypertensive, been dialyzed already. His weight is 97 kilos. Cardiac chest examination normal, no pericardial fracture rub. Abdominal examination apart from presence of bilateral flag tenderness and marks of Hujama on back. It looks inflamed. Mild to moderate lower limb edema and peripheral pulsations were intact. He's not anemic, hemoglobin 12 point something, ESR 35, A1C 6, and his blood group AB. Creatinine 7 is already on dialysis, calcium 10, phosphorus 4, total protein albumin acceptable, normal enzymes, his CPK 230. Urine analysis, the few CCs that we have, specific gravity 10-0-10, WBC is 12, RBC, that's a Foley catheter, 30 to 40 red cells per hyper field, protein 0.3 gram per milligram. EKG, echo, chest x-ray, all that really looks fine. Now the ultrasound, normal size kidneys without hydronephrosis, increased echogenicity with prominent pyramids, poor blood flow to both kidneys by Doppler. That's really when we spoke to our ultrasonographer. Serology, all negative. Hepatitis B, C negative, ANA, DNA complements, ANCA, MPOs. You have to remember acute kidney injury in the elderly, you have to think seriously about ANCA. It's the commonest cause of acute kidney injury in elderly individual. Anti-GBM antibody or negative. So, all workup is negative for gentlemen, 2 weeks history of severe flank pain, non-steroidal use recently, mild hematuria, mild proteinuria, normal size kidneys, no obstruction. What's differential diagnosis?
We have some inputs from our young fellows. Mostly they related it to the use of a drug, and one suggested directly for papillary necrosis, probably related to his history of recent use of non-steroidal. So these are most of the choices. It is drug-induced acute interstitial nephritis, plus minus papillary necrosis. These are the most of the inputs from our young fellows.
Okay. So this is, I'm not going to go through this, but that's when you think about it, pre-renal, renal, pre-renal, renal, and post-renal.
Yes, sir.
I don't think that we have any of these here, but you have to remember that pre-renal contains also blood vessels. You have to think about arterial occlusions, stenosis, cholesterol embolization. That's one thing in the pre-renal area. That to keep an eye that his blood flow to the kidneys were poor. Mm-hmm. And then you have intrinsic, post-renal, there is no obstruction. And as you'll come here, vascular component, vasculitis, GN, as I mentioned early on, component, you have the vessels, vasculitis, GN, and interstitial nephritis, acute tubular necrosis, whether ischemic or nephrotoxic. Nephrotoxic will be endogenous or exogenous. We're not going to go through this. But basically, that's the list of things you have to think about. So this patient here, yes, we need to have a kidney biopsy. What do you expect to see in the kidney biopsy? Still drug-induced.
So is it a drug-related process or it is a vascular-related process? what do you think that the pathology would be? Yeah, Shabab, any input?
Still there is hematuria, and there is some white bcuria. يعني, let's see the opinion of the students.
Is Hammam around with us or he left?
I think he is with us, I think.
Hammam, write your choice. Hammam, our third year fellow.
No, he's left. He just left.
Apparently he left, yes.
Yes.
Okay, so let's see the biopsy. 20 glomeruli for immune fluorescence. This is the kidney biopsy. What do you think? That's on light, low power. Anyone would like to describe what they see?
Yeah, Shabab?
There is interstitial infiltration, but
Well, let me tell you, yes. But look about this part of the kidney. There is ghost of the kidney. You don't see any structure. Here you may see tubules. Here you don't see anything.
And there is
Look
evidence.
about this.
Is there any evidence of obsolescent glomeruli?
Well, we'll see now.
Yes.
Look about this. This is an infarcted kidney.
yeah, there's thrombi.
Look about this. Do you see any basal membrane? You don't. You see any viable tissues? You don't see glomeruli, you don't see tubules. And that's here, one glomerulus, which is infarcted. Look about this glomerulus. Mesangiolisis.
Yes.
Yes.
You don't see cells, you don't see anything. Same thing in the renal tubules. That's only one single normal looking glomerulus, and that's a patchy interstitial area disease.
1 out of 20 glomeruli.
Yes.
Yes.
Look about this. Very thick blood vessel, lumen almost close to be occluded.
Severe hyalinosis.
Look about this blood vessel. Look about the internal lamina, and that's all the lumen. Look about the lumen. Basically, very little lumen of the blood vessel.
Yes.
With this glomerulus, you don't see anything. See that blood vessel. How thick the wall.
Yes, sir.
That's sclerosing glomerulus. That's the area of interstitial infiltrate, possibly due to the drug that he received.
Yeah.
See here, that's the infarcted area, special stain, that's the blood vessels.
Mm-hmm.
Look about this. That's the intima, and all that's really thickened. Same thing. Negative for amyloid. Congruent patient negative, that's fibrin. So we have infarcted kidney, consistent with renovascular occlusive disease. And that's, if you remember, the ultrasound demonstrated poor blood flow to the kidneys. So poor gentleman, this gentleman, he developed severe flank pain. It was thought to be a colic or anything like that. And he was given non-steroidal. The end result, it was missed as a renal infarct.
Patient receives, did the patient receive any prior anticoagulant therapy?
No catheterization, no cardiac cath, nothing really, and there is no history of fibrillation.
It can happen without any risk factors.
That's true.
It can happen without with any risk factor. Being an elderly with atherosclerotic aortic disease, they can shower their emboli at any time.
That's true.
Yes, sir. Yes, sir.
Yes.
So that's
Anything that we may send our patients for Hansen stains for eosinophils in the urine, Ammu Riyad?
For what?
Hansel stains for
All
eosinophil in the
there.
urine, you know.
Right stain or Hansel stain for
Hansel
eosinophil.
stain.
Yes, it can be done. Yes, it can be
It
done.
can be done because the differential diagnosis of eosinophiluria can be easily two in nephrology. One of them is the allergic interstitial nephritis, and the other one is the renal atherosclerotic disease, sir.
Yes.
Yes, sir. Yeah.
So renal infarct, basically, you know, it's a catastrophe. You know,
Yes, sir.
if you look about renal infarct, you may have cardiac in origin, most of it. You have renal artery injury. You may have hypercoagulable state, or you may have idiopathic. As you'll see, the age bracket, just I'm not talking about cardiogenic, 65 years elderly, renal artery injuries, trauma or water dissection, Marfan's polyarthritis nodosa, compression, your age bracket is young. Hypercoagulable state, you have to think about it, malignant and others, always there, nephrotic syndrome patient, and you may find no reason really. But most of the time,
as I mentioned, احتمال تصير بأي كبير بالعمر and it will mislead the nephrologist.
The reason why it's being missed, because flank pains, they think about stone, colic. They will go to the urologist. Especially when we have two patients, they lost their kidneys. First, they went to the urologist, and then later on, flank pain, nothing was found, and it was to be lupus anticoagulant. You have to remember that.
Unfortunately, Amuria, renal atherosclerotic disease can. What do you think about the diagnosis, the prognosis, Amuriat? I think it's
bad. It's bad.
They will lose the kidneys.
And that's what happened with this patient, because it's late. When they present to you, it's late.
Amuriat, عادة when it comes settled chronic without any important symptoms, I think the prognosis for those patients is bad. They usually will lose their kidneys.
That's
نعم
true.
عمرو صحيح. Yes sir. Yes sir.
Okay. We have time for another case.
Yes, sir. Yes.
Here, a female patient, she was referred to our Center for Evaluation Potential Kidney Candidate for Transplantation from her brother. History dates back nearly for a few weeks prior to her presentation, when she developed shortness of breath, fatigue, and poor appetite. Mild lower lymphedema, early morning puffiness, history of arthritis, no history of arthritis, rash, fever, night sweat, or weight loss, no history of recent medication. She's not diabetic or hypertensive, Jeep, Gravida 4, Para 4, without any history of pre-eclampsia. Not in acute distress, normotensive, cardiac exam normal, no RAP, abdominal examination, no organomegaly by palpation, bilateral flank tenderness was really present but not masses, no peripheral edema at this time, CNS grossly intact. She's anemic, PT, PTT were normal, AS are slightly up, serum creatinine 6.8. Calcium, phosphorus, blood sugar, liver function, looks really fine. Here, the urine, RBC is 4 to 6, white cells less, no bacteria, no crystals, protein 1.3 gram per day. Negative culture. Ultrasound, large kidneys, you have to remember, large kidneys 11.5 and 12 point something. Increased echogenicity, no hydronephrosis, but there was prominent pyramids. Just keep this in mind. Chest X-ray normal, normal echo. What other tests do you want to order now? Basically, for.
So a patient who is multiparous, no history of abortion, no history of PET, presented as a candidate for transplantation.
That she was referred really
for transplant.
For transplant with her, with her brother, with her to donate a kidney.
Yes.
She was seen by the urologist first, who's really a friend of mine,
Yes.
And he said, well, I can't do anything for you. Go to Dr. Riyad and let's see what will happen. When I saw her, that, well, I don't think that really this is something looks acute.
Yes.
I don't think that really you need to have transplant for the time being. Urine
Because
eosinophil, that's what Safa was asking for, negative.
yes.
Serology, all negative with complements. Young female patient, with this picture, we have to rule out lupus, though symptom-wise is negative.
Yes, exactly.
And now what we think now, mostly drug-induced interstitial nephritis, though she's not really mentioning that. Now, my job really here, or the job of our student, is to tell the difference between acute and chronic kidney disease. Makes a lot of difference.
This is a very important point. Yes,
okay, that's really the, in order to call chronic kidney disease, at least you need to have 3 months. Don't rush for transplantation for a patient who's coming just with recent disease that we have. Hemoglobin, I highlighted it, the duration of the disease, the normal hemoglobin, the normal size of the kidneys, and others. These are indicates active urine sediment. All they look about acute. Okay, but you have to remember there are exceptions. You may see anemic patient with acute kidney injury, hemolysis, microangiopathy, and bleeding. You may see normal size kidney, but in chronic kidney disease, the size of the kidney is small. But a polycystic kidney, obstructive uropathy, infiltrative disease, they have large kidney. Anything we have, there is an exception. But overall, this is how you tell the difference between acute and chronic. It's a must to determine this. Once you really say acute, then you move on to etiologies. Although anemic, this patient, but she has a normal sized kidney with quite prominent pyramids on ultrasound.
Yes.
Pyramids indicates increased
Acute.
interstitial edema. And that's why the columns of Pertini that we have will be more prominent. It looks like pyramids in the kidney. That's a good sign, especially when you have a normal size or increased size kidney. She has short duration of the illness, previously healthy, not diabetic, hypertensive, there is no preeclampsia. So all this indicates that we are dealing with acute kidney injury. And that's basically what you think about pre-renal, renal, post-renal. I think we discussed this. We are not going to repeat it. The only thing missing is this here, the interstitial nephritis, which is, we have no vasculitis in this patient. We have no acute GN. We don't have acute tubular necrosis. And we have not pre-renal, post-renal. So if we are lucky, let's concentrate on this category. And that's how we really, when we teach our students, this is the way we go through differential diagnosis.
Yes.
So acute kidney injury, I think we mentioned this here. Our next step, I think we should have a biopsy. There is no need to waste time. We have to have a kidney biopsy. So we did the biopsy. We are generous. We have one patient at one point, we have 96 glomeruli. So our fellows were really so generous, taking four goes. And usually we go 3 goes, and we have a good number satisfactory kidney biopsy.
Yes, sir.
This is her kidney biopsy. Looks from far, low power, not bad at all.
No, it looks a good kidney.
Looks really acutely. Tubules are fine. There's maybe a patch of interstitial disease here, infiltrated. The number of glomeruli looks good. And that's the glomeruli, that's glomeruli. This is an area of dense interstitial infiltrate. There may be some interstitial edema. This is fluid, that's not collagen. Look about the tubules that are separated okay, from each other. That's the glomerulus. Beautiful looking glomerulus. There is nothing wrong with this. There is normal capillary loops, mesangial cells, which is good, 3 to 2, all that. Here, very nice capillary loops. There is no mesangial matrix increase. And then we come to this area.
Yes, sir.
Seeing large area of interstitial infiltrate. There is an eosinophil, 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 eosinophil.
Yes.
It's a really good number of eosinophils in the urine, in the specimen. Not only that, but you see in the renal tubules. And that's why you see it in the renal tubules, some eosinophils. If you have it there, I think ideally we should catch it in the urine. But unfortunately, the urine sample was negative for it. Look about this. See this area, sclerosed glomerulus, and all this severe mononuclear cell infiltrate with abundant eosinophils. Under higher power,
it's an allergic one, sir. It's an allergic.
See how beautiful looking these eosinophils here.
Yes, sir.
That's the state, normal glomerulus, that on trichrome state, there is no fibrosis. There's no fibrosis. And that's really what we mentioned. That's all fluid, that's edema, interstitial edema. So we have 9 glomeruli, all negative with immune fluorescence. Special stains are nothing really there. Blood vessels not thickened, and all is sclerosed glomerulus. Why this here? So it's acute interstitial nephritis, mostly drug related. She was treated with steroids.
Exactly.
Yes.
Sir,
Yeah.
sir, can I have a question? If you have a strong clinical suspicion that this is a drug-related acute tubulointerstitial process,
do you biopsy her or not?
No. For this lady, I will go straight forward for biopsy.
Yeah, she's coming for transplant.
Yes, this is very, very important. The biopsy is here, and even her representation is not usual. Her serum creatinine is very high, so this is acute unexplained acute kidney injury. We should go for biopsy. But I would like to. My question is that if you have a very good level of suspicion that this is mostly acute tubulointerstitial nephritis, do you embark on steroid prior doing biopsy?
Well, I'll tell you, our biopsy findings, we will have it within 24 hours. So, yes, you may give her, if I'll see her today, for example,
yes,
I'll give her 1 gram solimidrol, and then next morning I'll have the biopsy.
This is important, yes.
Well,
because sometimes just to save the kidney.
My threshold for steroid is quite low, so
yes,
I'll give steroid therapy.
Yes, sir.
أستاذ رياض، هو بالclassical teaching عمو رياض, when you suspect an acute allergic interstitial nephritis, whether drug or environmental or supplement or other thing, that you should wait for a few weeks for the spontaneous recovery of the kidney. Steroids are indicated by many others, and sometimes you may reach using immunosuppressive agents. But in patients with age more than, for example, 55, 60, when there is comorbidities, when there is another differential diagnosis, I think the biopsy will solve the problem in most of the cases, Ustad Riyad. I don't think that there is a strict criteria to do a biopsy for those patients. It's optional for the patients per se. So the nephrologist can indicate a biopsy for this patient or contraindicate for another one.
By the way, yes, again, we are really very liberal in doing kidney biopsies.
Yes, sir.
Ustad Riyad, in every center, when the complications of kidney biopsy are very low, like your center, then you can do it for academic reasons, to diagnose patients more and more. I think that the biopsy was very crucial for this patient, Asha Ustad Riyad. Just to show that at least that she's coming for a grave insult, that she wants to be transplanted, sir.
Imagine this patient. Imagine this patient. Someone will go and transplant her.
Probably some nephrologists would go and transplant her without any reason for doing that, sir. It was a very good reason to biopsy her, sir. Very, very interesting, sir. Very interesting.
Steroid therapy did very well. Look about her creatinine. came down nicely
Huh?
to 1.3. She's a wife of an orthopedic surgeon, and seen later on perfect kidney function. And 3 months later, she came in with pain in both eyes. Here is Ala.
Yes, sir.
Redness and blurring of vision. No lower lymphedema, no urinary tract infection, no recent history of antibiotic intake. Seen by the ophthalmologist, was told that she has uveitis. She was given
استاذ
local
هذا
steroid therapy.
ينطبق المثل الانجليزي اللي يقول you are reading my lips حتى قبل ما احكي ده تفكر بافكارنا استاذنا.
A local steroid was given to her with little improvement. So, repeat evaluation, because now you have a patient with systemic illness.
Yes, sir.
Vasculitis. Yes, we have drug-induced. All the workup as we have previously was negative. And from renal point of view, she was doing well. Blood pressure 130/80, serum creatinine 1.2, proteinuria 0.3, and she was given methotrexate. Now the ophthalmologist gave her methotrexate weekly, was given by the ophthalmologist in addition to local steroid therapy for presumed uveitis. So now we have a diagnosis of TENU syndrome, tubulointerstitial nephritis with uveitis. Any comment?
عمو تاينو is a diagnosis of exclusion مثل ما قلت حضرتك من الهيستوري كله ما بين شيء من الكولاجين فاسكولار سكرين ما بين شيء. The uveitis may antedate or post-date the diagnosis of acute interstitial nephritis and Tanu disease.
That's true.
And as I mentioned in my previous talk, it's hardly to be, it can be granulomatous, but I think presentation is nophilic interstitial nephritis with uveitis, which post-date interstitial nephritis fits to this woman. So I think your thinking was great, Amr Riyad, that this patient was fortunately present with her uveitis to declare her the diagnosis, Amr Riyad.
Yes.
Very interesting, Amr Riyad, very interesting.
So that's TENU syndrome was described for the first time in 1975, and it's mostly ocular findings. It can be seen in sarcoid,
yes,
Sjogren disease, lupus, Wagner, Behçet disease, infections like TB, Brucella, Toxoplasma, and others. So that's the TENU syndrome. The uveitis usually treat steroid therapy, interstitial nephritis, systemic steroid for progressive renal disease. They used for the eye a lot of medication. Fortunately, this patient only did well on the methotrexate. Yes.
Yes, sir. عم رياض هو التاينو مشكلة تشخيصها يعني مثل ما قلت حضرتك انت لازم you exclude all things that are available, infections, especially in our area, that's very common. يعني I think that the تاينو أنا عندي واحدة مريضة تاينو وظليت أستاذ رياض أكثر من سنة أدور على بهجت أدور على SLE. I repeatedly sent her for the complement system for the just to prove that she's away from a collagen vascular disease, and that was true. And sometimes there is reports of Thaino syndrome, Amr Riyad, that they may reach to immunosuppressive therapy, that steroids that may either will be toxic or they will not be benefit. Yes, you can proceed to azathioprine or cyclophosphamide therapy just to control them, Mr. Riyad.
Yes. Now, the teaching point from this case that really, please don't rush.
Yes.
Parahistory is quite important. Complete evaluation search for potential curable cause or at least reversible cause of renal failure. Do not rush for kidney transplant. Give a chance for potential recovery of renal function. That's really important.
عاش ايدك استاذ رياض.
شكرا جزيلا
ايدك اليوم استاذ رياض. تعلمنا والطلاب تعلموا how to be outlined for their management, how to approach their patients well, history taking, proper lab exam, your wisdom in managing your patients, and that's the message behind your lecture today. Wisdom and make things easy. Just think of common things and rare things to be always to be thought of. And that was behind the message of your talk today, Ustad Riyad. Thank you a lot. Thank you, Ustad Riyad.
I think that's enough for you for tonight.
Yes, sir.
If you need more, I'm ready.
لا استاذ ما نحب نتعبك لا استاذ. احنا بالعكس نريد نستغل الامور على another session clinical discussion and the clinical cases.
لا اني مو تعرف اني حاضر مرتين مال عمو رياض مال اسد بيس. لازم الطلاب يسمعون
راح نسوي
اي لازم يسمعوا من عمو رياض. هاي يعني اني قلت للاستاذ رياض يسمعوه ويعطيهم اكزامبلز يقعدون يحلون وياه. فاهم شيء الاسد بيس for the next time دكتور استاذ رياض.
If you need to continue next time, we have another cases, transplant cases in the same format.
استاذ ممكن نقسم السيشن القادم. يعني اذا احنا رحنا يعني اخذنا 2 hours ممكن نبدي اولا يعني بعد اذن حضرتك وحسب توقيتاتك اذا ممكن نبدي مثلا الساعه 9 for 2 hours. 1 hour نكمل الباثولوجي، 1 hour نكمل ناخذ clinical cases بالاسيد بيس بالانس، ايضا يكون انتراكتيف ومتنوع.
ما عندي مشكله ابدا.
واحنا راح نرتبها ونسوي عليها بروبر اناونسمنت في وقتها مبدئيا على يوم 25 ان شاء الله، يعني مو الجمعه القادمه اللي بعدها ان شاء الله.
give me whatever you want.
على تعرف شنو المشكله؟ يعني انت اريد هاي الكيسز مال اسيد بيس ويا استاذ رياض تكونوا بسيشن واحد دكتور علاء الله يخليك. هو احنا نقدر نعطي التيتشنج كليته لعمو رياض ما عندنا
ابدا
ما عندنا مانع بالعكس احنا نكيف نفرح يعني.
الساعتين الجايه استاذ رياض اسيد بيس على طريقتك اللي سمعها من عندك وياها clinical cases they should learn it. اوكي عمو رياض؟
اوكي هي done. اذا على يوم 25 ان شاء الله. استاذ يناسبك الساعه 9 او الساعه 10 ان شاء الله؟
اللي يناسبكم انتم، انا ما عندي مشكله.
يعني ان شاء الله نتفق عليها ونرتب الامور باذن الله. الله يحفظك
ان شاء الله عمو رياض.
ممتنين جدا. تحياتنا لحضرتك.
الله يخليكم.
شكرا جزيلا. شكرا
استاذ
جزيلا.
رياض ممنون، يعطيك الصحه والعافيه ان شاء الله استاذ رياض. ثانك يو الله. ثانك يو.
شكرا استاذ. تصبح على الف خير استاذ. مع السلامه.
اهلا دكتور علاء. لا